So the topic that is given to me, role of Atezo plus Bev as first line in unresectable HCC. Next slide. Next slide. So we all know that the liver cancer are among the highly lethal cancer, and it is the 6th most common cause of cancer overall. And you see the mortality-wise data, it is a 3rd leading cause of global cancer mortality. Next. And we all know that liver cancer is highest in especially the developing countries. Next. If you see the whole spectrum, the hepatocellular carcinoma comprises almost 90%. And other cancer that are very uncommon, these are cholangiocarcinoma, angiosarcoma, and hepatoblastoma. Next. If you see the etiology of HCC, the most common factor is chronic hepatitis, and that is caused by either hepatitis C virus, hepatitis B virus, alcohol, non-alcoholic steatohepatitis, or aflatoxins. And after that phase, the cirrhosis phase develops, and from cirrhosis, there is a early HCC development, and then subsequent advanced HCC development occurs. The core event in whole the pathology are there is a hepatocyte damage plus stellate cell activation. So most common cause in 80 to 90% cases are cirrhosis, and then subsequent HCC. Only 10 to 20% cases of HCC don't have the cirrhosis as a etiology. And if you see the genomic profile, most of the patient has profound genomic alteration with epigenetic modification, and some have a growth factor pathway alteration. Next. So if you see the Indian scenario, it is very bad actually. Next. Most of the cancer that we see in our private OPD are advanced stage, and usually they have the very high mortality rate. And if you see the 5-year survival rate, it is only 2 to 3%, and it is very dismal. And if you see the current options available, the TKI with median overall survival of 1 year only, and very poor PFS and quality of life. And also we have the lack of the updated data and updated Indian guidelines. Next. So if we see the FDA approved guidelines for advanced HCC, the first drug that is approved is sorafenib. That is way back in 2007. And the trial for that is SARP trial, and they compared sorafenib with placebo, and they got a 3.4 month overall survival benefit in advanced HCC. And from 2017 to 2020, there are multiple drugs that are approved by FDA. If you see the in first line, there are TKI that is lenvatinib, and then Atezo plus Bev. And if you see in the second line and beyond, there are regorafenib, pembrolizumab, cabozantinib, ramucirumab, and nivo plus ipilimumab. Next. So what is the rationale to combine Bev with Atezo? Bev is an anti-VEGF property, and Atezo is a PD-L1 inhibitor. Next. So there is a definitive role of immune escape phenomenon occur in HCC tumors. Whenever tumor develop, surely there is infiltration of the immune, that is T cells, in the tumor microenvironment. And both if there is a killing of the tumor cells by the immune cell, there is no escape, no immune escape phenomenon occurs. But if there is a immune escape phenomenon are there, there is evolution of the tumor cells occurs. Next. So if you see the exact role of bevacizumab, the bevacizumab is an anti-VEGF inhibitor. with additional immunomodulatory effects. And if you combine with the Atezo, the Bevacizumab may enhance the Atezo's efficacy by receiving the VEGF-mediated immunosuppression and helps for immune escape phenomenon. Next. So basically, we see the IMBRAVE 150 data, and it's a phase 3 open label trial. Next. And they compare Atezo plus Bev versus sorafenib, and they selected the patient of locally advanced or the metastatic or unresectable HCC patient, and they have not taken prior systemic therapy. The stratification factors are according to the region, ECOG PH status 0 or 1, according to the presence or absence of the macrovascular invasion or extra hepatic spread, and they included the high risk patient mostly in 20%, invasion of the main portal vein with bile duct, and more than 50% of the liver occupying tumor. And also the baseline AFP, whether it is more than 100 or less than 100. The main co-primary endpoints were OS and PFS, that is IRF assets, that is individual review facility based, and the key secondary endpoints were overall response rate and Atezo plus Bev versus sorafenib, that to be continued till progression. Next. So if you compare the intention treat analysis patient list, mostly 82% patient are from BCLC stage 3C, and odd 70% patient are affected with either HBV or either SCV infection, and approximately 77% patient has extra hepatic spread and macrovascular invasion, and almost 50% odd patient had received a local therapy for SCC. Next. So if you see the PFS data, the lines are separating, and the Atezo plus Bev has 6.8 month PFS compared to sorafenib, that is 4.3 months, with significant p-value, and HR is approximately 0.59. Next. And what patient gave the subsequent line are usually the sorafenib arm. They have 26% of the patient taken immunotherapy and a tyrosine kinase inhibitor subsequently. And for Atezo plus Bev arm, usually less patient have received subsequent tyrosine kinase inhibitor and chemotherapy. Next. If you see the overall survival data, next. So if you see the updated OS data that is published in the April 2022, the Atezo plus Bev arm has 19.2 month overall survival data compared to sorafenib, that is 13.4 month, and p-value is significant with HR 0.66, and lines are clearly separating. Next. So if you compare the patient with baseline characteristic either for ECOG status, BCLC B or C status, either a patient affected with the HBV or SCV infection, viral load, AFP level, extra hepatic spread, in all the aspect, Atezo plus Bev do better compared to sorafenib. Next. And if you see the response rate, the Atezo plus Bev arm has almost 1.5% double response rate compared to sorafenib. Next. So almost, if you see the updated data in April 22, the response rate of Atezo plus Bev arm has 30% response rate compared to sorafenib, it is only 11% response rate. Next. Next. So if you see the side effects of the both arm, the most of the side effects are diarrhea, hand-foot syndrome, decreased appetite, hypertension, abdominal pain, alopecia, asthenia, pyrexia, increased transaminitis, proteinuria, and infusion-related side effects. And if you see the dark pink and dark blue line, these are the grade 3 and grade 4 side effects. So usually there are more occurrence of the side effect with the sorafenib, except there is dark blue one with the hypertension. 50% patient develop grade 3 and grade 4 side effect with Atis plus Beva. Next. So if you compare the rate and grade of the bleeding event, it is similar between two arms. Next. And also the bleeding rate is very mild and low, and that is also the not related to the basic gastric paralysis. Next. And if you see the hepatitis side effect, that is also a similar between two arms. Next. If you assess the IMBRE 150 data, there are three assessment tools. First is the quality of the life. Second is the physical functioning and the patient's role. And third is the symptom control, either fatigue, pain, appetite loss, diarrhea, and jaundice. Next. So if you see the time to deterioration rate in both arms, that is Atezo plus Bev and sorafenib, it is 11.2 months time to deterioration rate, and for sorafenib it is 3.6 months. So that is clear cut lines are separating with HR of 0.63. Next. So the definitive improvement of quality of life for those patients who are on Atis plus Bev compared to sorafenib. Next. So if you see the symptom-wise side effect of a patient list, that is appetite, diarrhea, fatigue, and jaundice pain, in all the aspects, Atis plus Bev do better compared to sorafenib patient. Next. So if you see and complete the data for systemic therapy for HCC in the first line setting, the standard of care is Atis plus Bev, sorafenib, and plenotinib. All you can use in the first line setting with the Child-Pugh A criteria patient. And if patient progress over the above drug, then patient can be offered regorafenib, Atezolizumab, ramucirumab, pembro, or nivo. Next. So if you see the NCCN guideline, if the liver tumor is resectable, is it a transplantable, or if it is unresectable temporary, then you can offer a local therapy to those patients. But if it is clear-cut inoperable by some specific factors, you have the options of locoregional therapy that is preferred. And if at all locoregional therapy is not being offered, then systemic therapy has a definitive role, including sorafenib, plenotinib, and Atezo plus Bev. And if patient is clear-cut metastatic setting of HCC, there is definitive role of systemic therapy, including sorafenib, plenotinib, and Atezo plus Bev. Next. So we can conclude that if patient has an advanced stage of HCC with Child-Pugh A criteria and ECOG PS 0 or 1, so patient is stable. So we can use Atezo plus Bev in this patient, or tyrosine kinase, sorafenib, or plenotinib. And in second line, if we primarily use sorafenib, so if we used sorafenib, then we can use Atis plus Bevacizumab in second line setting also. Next. So if you see the ESMO guideline, they clearly mention for the BCLC stage 0 or A and stage B, you can offer a local therapy to the patient. And for stage 3, stage C, there is option available for systemic therapy as a first-line therapy. Either you can use tyrosine kinase inhibitor or ATIS plus Bev, and patient progress over the above systemic therapy. There are options of the Regorafenib, Cabozantinib, and Rabosumab. Next. So, if I want to conclude my talk, ATES plus Bev demonstrated a great efficacy in phase 3 trial, that is Ambrev 150, and it has a clinical significant improvement in overall survival and PFS compared to Sorafenib. And also, it has a clinical meaningful delay in time to deterioration of the symptoms compared to Sorafenib, and that subsequently improve the quality of life and physical functioning of the patient. So the positive data of ATIS plus Bev, by that you can benefit the patient most and help the patient to escape from that immune related points. So I think it's the next, I think it's the last slide. Thank you.
Thank you very much, Dr. Gaurang, for this wonderful